A recent graduate from the Stanford psychosocial program, and she is going to be continuing on at Stanford in the psychosocial clinic, continuing to work with our lab. And also she is a part of a new private practice that she's launching called California Psychology Center.
Thank you, Carolyn. I'm going to share my screen. Hi, everyone. All right, let's do a 10-minute crash course in exposure and response prevention. Let me get into present mode. Here we go. My screen good, Carolyn? Okay, awesome. Well, hi, everyone. Thank you so much for joining us this morning. As I mentioned, we're going to talk about exposure and response prevention. I could spend 3 hours talking about this, but we're going to do it in 10 minutes. So let's jump in. First question is, what is it? And exposure and response prevention is behavioral therapy that exposes people to stimuli that bring up those unwanted intrusive thoughts and those accompanying emotions, anxiety, general distress or discomfort, while encouraging people to resist engaging in those compulsive responses. That's the response prevention part. I'll talk a little bit more about how this works, but it is the gold standard for treatment for OCD. And I added a little bit of sage wisdom at the bottom. I've never called myself Dr. V before, don't know how I feel about it, but response prevention is huge. It's crucial to the entire treatment. We can do the best exposures in the world, but if we then go and do compulsions afterwards, we're not going to see the gains and success that we typically would want to see. This is OCD doodles. They're on Instagram, they're wonderful. But this is just a little image of how the OCD cycle typically looks like. So folks with OCD have unwanted intrusive thoughts, doubts, urges, images that pop up, which ultimately lead to doing compulsions to neutralize the thoughts, alleviate distress that's accompanying the thoughts. And then there's a couple other components here. So for example, lots of people have intrusive thoughts, but folks with OCD might attach meaning to these thoughts and might get more stressed out by the thoughts than people without OCD. When we engage in compulsions, we experience short-term relief from the feeling that we're trying to avoid, anxiety or disgust. And when our anxiety goes down, that's a reinforcement and makes us want to do it again and again. So intrusive thoughts about germs, distress, compulsions, relief, and then the cycle kind of continues over and over again. And I'm sure this is not news to most people here. Okay, so a little bit on how ERP, just again, exposure and response prevention works. There's these two frames of thought, habituation and inhibitory learning. And I put stars on inhibitory learning because that's where I see the field going and that's where I have gone. But habituation is where we started. So Edna Foa, coming up with exposure and response prevention, focused a lot on this idea of we need to do exposures and sit with the discomfort until it goes away, much like this bell curve down here. And the idea was you'll get used to it, you'll get over your fear will become extinct. That's really nice when that happens. So if you were to do an exposure to something that scared you and your anxiety went down during the exposure, that's probably going to feel really good. However, research shows that habituation isn't the best indicator of successful response to treatment. Some people habituate with every single exposure they do, and they don't find that they make long-term progress. On the other hand, some people never habituate. They go and do an exposure, their anxiety's 10 out of 10 the entire time, and they do improve. They do find treatment gains. So how do we make sense of that? Is through the inhibitory learning model. So in essence, we're not trying to get rid of the fears. I'm not going to be able to convince my brain that it was never afraid of dogs. I might still have a little bit of anxiety, even if I've done some work with getting through that fear. Instead, the idea is that exposure works by learning new information about safety, incompatible information. And this new learning inhibits the original fear learning. So for example, the dog example here. If every time I see a dog, I am running down the street as fast as I can, I'm teaching my brain a couple of things. One, I'm teaching my brain dogs are actually really dangerous and scary. And it's a great thing that I'm running away because that's a real threat. And two, we're also teaching our brain, hey, that fear, that anxiety that comes up, you can't handle it. You can't handle it. You better keep doing these things like running down the street or avoiding friends who have dogs. So when we do exposure, we are giving ourselves the chance to change our learning. Every time I go near a dog and nothing bad happens, my brain is going to go, oh, what's happening here? I'm with a dog and nothing bad has happened. And over time, we're going to create these new neural paths and we'll strengthen the ones about safety learning, and we'll replace or inhibit, rather, the old fear learning. And one of the things I really like about the inhibitory learning model is that we're focusing on tolerating discomfort rather than on habituation. We're learning that we can tolerate anxiety. We don't have to get rid of anxiety. Because at the end of the day, anxiety is a natural emotion. We all have it. It's important in a lot of ways. We're not going to get rid of it. But we can learn how to become a little bit more tolerant of it, or a lot more tolerant of it, hopefully. All right, different types of exposure. In vivo, imaginal, and interoceptive, just briefly on these three. And people will often leave out interoceptive for OCD, but don't do that. And I'll tell you why. So in vivo is the exposure that we can see. This is me sitting and petting a dog. This is me touching something that's contaminated. We can actually do this in real time. Behaviorally, you will see that I'm doing an exposure if you are looking at me. Great forms of exposure. However, not all things can be recreated in real life in vivo. And for that, we have imaginal exposures. So imaginal exposures are for, let me give some examples. If you're a mother and you have intrusive thoughts about dropping your child, we can't do an exposure to you dropping your child. We're not going to advise that. But we can do exposure scripts, or we can kind of zoom into those worst case scenarios and recreate it via stories or other things. And our brains will often have the same emotional experience as if we're actually doing the thing. So we can do exposure without doing the actual physical exposure. And interoceptive is exposure to uncomfortable physiological sensations. And the reason I said people often miss this one is because it was originally thought of as being only useful for panic attacks or panic disorder. But that's not true. Lots of people who have OCD have intense physiological reactions to anxiety triggers. Your heartbeat starts racing, maybe your stomach gets upset, you feel dizzy, and we can do exposures to those physical sensations to learn how to tolerate them. Again, it's all about tolerating anxiety, tolerating discomfort. As I mentioned, exposure is great, but response prevention is really where I kind of push and push. So the obvious here is that resisting compulsions is really hard. And sometimes if you're going into treatment, you might get the feeling that the person wants you to just not do it. Just don't do that compulsion, just stop. And while that is true, it would be great if everyone could resist their compulsions 100% of the time. That's how you're really gonna get effective treatment for OCD. It's not feasible at the gate all the time for everyone. So some other things that we might practice is postponing compulsions. Hey, can you wait 5 minutes before you wash your hands, or 5 minutes before you check instead of doing it immediately? We might do the opposite of what OCD is telling you. OCD says, stay home, don't drive. Let's go out for a joyride. Undo compulsions. So if you touch something contaminated, wash your hands, then it's touching the thing again to undo the compulsion, using rewards, and then stimulus control. So removing things that make compulsions easier. I talked about this already, but the goal of exposure response prevention is to create new learning, increase our tolerance of uncertainty, which is at the core of OCD, fear of uncertainty, increase tolerance of discomfort, to decrease our anxiety tolerance, and decrease compulsions. I know I'm going quickly, and that's because of time. Few more slides. So people ask all the time, why would I even want to do that thing? Why would I want to confront my fears and do all these things that make me very uncomfortable? And the question I would ask you is, well, what has OCD kept you from? Has it kept you from family, friends, or relationships, or maybe made those things harder? School, work, hobbies, goals. What has OCD gotten in the way of? And that's where you're going to find that answer of, why do I want to do this? Well, what is it impacting? Other options. So Dr. Keara talked about some medications and different drug trials. Of course, medication is always an option for ERP. Oftentimes I see folks who are doing exposure and response prevention and also on medications. Acceptance and commitment therapy is a newer, not a newer therapy, but more research is coming out on the effectiveness for OCD treatment. And I didn't add it here, but for some people, they might benefit from different therapies before doing exposure and response prevention. For example, doing dialectical behavior therapy before they do exposure and response prevention. Some of my favorite additions to exposure and response prevention, because it's really not just like, boo, here's the scary thing. We might add self-compassion, mindfulness, and values work. And one thing to be wary of and possibly avoid is this idea of cognitive restructuring, where we're challenging our OCD thoughts. Cognitive restructuring I've done with folks with OCD who also have things like depression, but we want to be careful because OCD gets really mad if we try to rationalize it away. We don't want to come up with evidence that our OCD thoughts are wrong because we're never going to win that battle. Will exposure work for me? There's only one way to find out. As Dr. Keara said, 50 to 60% effectiveness. I've seen as high as 85% effectiveness in some studies. So pretty good odds there, better than not trying. And if you are trying it and not seeing success, here are some things to look out for. Doing compulsions unknowingly, or maybe doing mental compulsions, and you're only looking for the physical ones, like checking, those kind of things. Avoidance, accommodation, maybe people in your life are making OCD comfortable by doing things for you. And there's always a possibility that maybe you need a higher level of care, or maybe you need a different therapist. Maybe you need to go back to the drawing board and make sure that the person you're working with has experience with OCD and ERP. I just wanted to address these because this is the reality, is that there's barriers to ERP. It can be really costly. It takes a lot of time. There's a lot asked of you in terms of homework and practice. And then there's always an access issue. So geographically, you might not have access, or there's really long wait lists. That's so ridiculous. Some ways that we've addressed access is by online therapy and apps like NoCD. But these still are very much a component of getting treatment for OCD, unfortunately. Okay, that's my time. There's my contact information. Please join me at 12:30 in breakout room 1 for Q&A and continued discussion on all things ERP, resources, etc.